Thank you, Joan, and thank you, Palchase, for inviting me and giving me this opportunity to share a little bit about our work at Pallium India. Pallium India is also home to the Trivandrum Institute of Palliative Sciences, which is the WHO Collaborating Center. So thank you, and I'll just share my screen. And Joan, if you can tell me if my screen is visible.
It is. Thank you, Smriti.
Thank you. Thanks, Joan. So just to give you a little bit of a landscape picture of what palliative care access looks like in India. This is the density of palliative care centers, non-governmental palliative care centers in our country. And as you can see, we have a long way to go. And of the 526 centers, 44.5% of these centers are just in Kerala. And I'm sure everybody knows about the Kerala model, but as much as I'm proud of it, I also feel that it is a bit of a glass ceiling in some sense, and it's very important for us to not try and transfer the Kerala model, but to translate it into different settings. So this is just to give you a little bit of an overview of what it looks like in India. Coming to Pallium India, we are a 20-year-old NGO, and we work on a model of demonstration, education, and facilitation. And as I mentioned, we are a WHO collaborating center, and we also have consultative status with the Economic and Social Council of the United Nations. Um, when it comes to demonstrate, we work out of Trivandrum. That is our headquarters. It's our flagship clinical services. And through there, what we really try to do is um, it's a proof of concept of what can be done in settings like ours. And within it, we have inpatient, outpatient home care services, a telehealth service, as well as a vertical dedicated to rehabilitation of our patients and their families. And we do all of this with the active participation of the community. And the Astana Declaration talks about involving the community and the people in the design and the delivery of healthcare, and that is something that we completely advocate. Every year, this is just a little calculation we had done. Every year, our home care teams in Trivandrum alone travel the equivalent of going around the earth 4 times to provide services to our patients. Coming to the educate part of our model, we conduct in-person and virtual courses for doctors, nurses, allied healthcare professionals, and volunteers. And through this, we also design and create modules that are contextual and specific to the settings that we're serving. And oftentimes, we go to different sites within the country and conduct the trainings there in their own settings. So this allows for ownership. It allows for us to also understand what their particular needs are and adapt the trainings to those needs. And with facilitation, what we really do is it's advocacy, it's supporting state governments as well as government bodies. And we work with both international, central government agencies, and very strongly with state governments and national health missions in order to implement the national program for palliative care. And we heavily rely on collaborations with other actors in palliative care in India and work with them and through them. And we provide knowledge and technical support to various organizations and institutions as required by them. When it comes to assisting with opioid access, one of the key features is that even though the Narcotics and Psychotropic Substances Act of India was amended in 2014 to improve access to opioids for pain relief, being a concurrent healthcare system, a lot of the state governments have not adopted it. So part of our job is to go and convene stakeholders in different states, take them through the new processes involved, not new now, it's been 10 years, but take them through the processes that have made access to opioids easier, because there's still a lot of paperwork and bureaucracy, and sometimes there is a misinterpretation of the law as it stands. So that is part of the facilitation work. As of 2023 December, this has been our impact. We have seen 25,000 plus patients, individual patients. We have worked with 76,000 plus family members and provided rehabilitation support to over 13,000 people. And through our training programs, 7,732 people have been directly trained by us. And through extrapolation, we have found that this is the number, 27 lakhs, those many patients that have been seen through the doctors that we have trained. And this impact is across 28 states and 6 union territories. I'll just tell you a little bit more about how that works. In as of 2023 December, we have worked with various state departments for training and facilitation. And we have assisted with the catalyzation of over 200 centers. Opioid access facilitated means helping, assisting people get their recognized medical institution a license in order to procure and dispense and prescribe opioids. We've conducted opioid availability workshops with those multi-stakeholder meetings, and various other activities that I won't go into detail, bearing in mind the time that we have on hand. But this has been our activity across India. I'll explain why there are those two bookmark photographs on this timeline. But just to take you through, my involvement with Pallium, with palliative care, began a little after the year 2000, when my adoptive mother died of cancer, and she died very painfully. And at that time, there was no talk of palliative care, at least in the circles that I knew. And by 2003, we had experienced 5 more deaths in our immediate family. And along this timeline, these are the milestones that India has crossed, and we have palliative care being recognized as a subspecialty. The Indian National Program for Palliative Care was created in 2012, which we assisted in the creation of. 2014, which is 10 years ago, we had a huge victory in the sense that the Narcotic Drugs and Psychotropic Substances Act, which was actually a tremendous barrier to access to pain relief, was finally amended after 19 years of advocacy by civil society. And following that, we've had palliative care included in the Indian National Health Policy. It's been included in medical and nursing curriculums. While this is a lot of progress, why I have these two photographs on either side is to tell you that while my adoptive mom died of cancer in 2000, quite painfully, like I said, in 2023, my biological mom died of interstitial lung disease, and she needed oral morphine for her breathlessness. And in spite of being associated with the WHO Collaborating Center in the state of Uttar Pradesh, it was next to impossible to get access to immediate release oral morphine. And it was because of the privilege that I have of knowing who to call, knowing the law, recruiting a local doctor to write the prescription, and then having oral morphine sent from Kerala, which is about 1,952 kilometers away. That's how the oral morphine reached us. So while on paper we've made a lot of progress, the reality on the ground is not very encouraging, because if someone like me has difficulty accessing oral morphine, I don't know what it's like for people who don't have access to all the folks who work in this field. Um, and finally, I will just end with this. We talk about the principle of balance a lot internationally, and the principle of balance really is the member states across the world are asked to abide by this principle of balance, where you prevent illicit and misuse of controlled substances, but you have to make them available for medical and scientific purposes. But usually this debate is centered around harm versus value, and it's restrictive versus enabling. You have people on both sides, and unfortunately right now access is mostly it's governed by control and laws that control and regulate access. But what we really need to think about in this entire debate is who is at the center of it, this patient and the family, and that's where the balance lies. So just taking from the India experience, we have to really focus on the suffering of the individual and the family, and see what is it that they need, and do they have access to it, and what is hampering that access. Something can be available but not accessible, and we need to understand why that gap exists. And especially in low and middle income countries like ours, we have to focus on safe access, not just more access. And we have to do it through high quality data. And for that, we need to build evidence, we need to do research. And finally, everywhere, not just in Kerala, but even in Telangana, where Dr. Gayatri Palat and her team have done a tremendous job of bringing palliative care to 33 districts, everywhere where these models work, it has worked because there is a partnership between the government that uses its mighty, mighty infrastructure, professionals who know the science, and civil society who will do the advocacy. And unless these three are in lockstep, we're not going to make a lot of progress. So I will stop with that, and I'm happy to take any questions that might come up later. Thank you, Joan, and thank you, everyone.
Thank you so